All right, y'all. Let's talk about cardiovascular emergencies. There's a significant call volume that you guys will have where people are going to call you for chest pain. Only a portion of those chest pain patients are going to be actual cardiovascular emergencies, but a whole lot of people in today's world have heart problems, and it's a big deal. And you'll see, you guys have all seen the Bayer aspirin commercials and blah blah blah. Everybody knows, call 911 if you have chest pain. Cardiovascular disease kills, or 63 million Americans have one or more forms of heart or blood vessel disease. There's roughly 300 million Americans, so that's about 1 in every 5 people. Okay? 50% of all deaths in the U.S. are cardiovascular disease. Okay? So this will be a lot of what you guys do. Okay? The first term you need to know is an AMI, or an acute myocardial infarction, is the leading cause of death in the United States. Okay? That's kind of our big moneymaker, all the little squiggly things. Paramedics show up to your house. It's our job to detect AMIs in progress and get you to the hospital and get it corrected. 1.5 million Americans will have acute MIs this year. Of these, a third of them will die. Okay, so 1 out of 3 AMIs will die. 350,000 will die in the first 2 hours. So nearly, that's, what is that, 7/10 of the ones that will die, they die in the first 2 hours, which is generally when we're with them. Okay. So acute coronary syndromes, or ACS, that is what we term a patient when we think that it is their heart that's having some sort of problem, and we're treating them with our oxygen, nitro, aspirin regimen. That's an ACS patient, or an acute coronary syndrome. That could be an AMI, acute myocardial infarction. That will show up as a non-ST segment elevation, or a non-STEMI, or an ST segment elevation STEMI. For us as EMS, or paramedics in the field, for us to call it, we're looking for this ST segment elevation, which on your wall right here, so this is called your P wave, this is called your QRS. This portion right here, this is your ST segment. This is the end of your S wave. This is your T wave. This gap right here, notice it looks like it's in line with the rest. Well, if this elevated like that, that would be ST segment elevation. Okay? And that's what we look for. That tells us that there's a delay in the electrical conduction getting around the heart, and so that tells us that there's an injury pattern. And when we do this, we do a 12 lead, what's called a 12 lead, where we look at 12 different views of the heart. And based on where this elevation occurs, we can tell you which artery or which portion of the heart is being affected. Okay, but that's what we look for there. Not every patient is going to have those changes, though. A significant number of them are non-STEMI MIs that they just present with chest pain, and so they have to use blood work. They do cardiac echoes, ultrasounds, things like that to determine whether they're having a heart attack or not. So acute MI, that's the big one. That's the one that kills them. Then we have what we call unstable angina pectoris, which basically means muscle chest pain, okay? And stable angina pectoris, which again is chest pain but stable. And you guys, stable versus unstable, what's the difference? How do you tell if someone's stable or not stable? Come on, y'all know this. Speak up. Don't be shy. How do you know if a trauma patient's stable or unstable?
If they have something life-threatening, or if they're suffering from something.
Okay. Think in terms of shock. What are the early signs and symptoms of shock? Is your patient showing signs of shock or not? So I can have chest pain and not show any signs of shock. That would make me stable, right? If I'm having chest pain and I'm showing some sort of sign of shock, such as I'm really anxious, maybe my heart rate's too fast, maybe it's too slow, Maybe my kappa refill is delayed. Maybe I'm short of breath. Okay? Any of those combination of things, you start seeing those early signs or warning signs of shock, then they have unstable angina. You guys get it? Okay? Okay, risk factors of heart disease. We break them into categories of major, uncontrollable, and then controllable. So age, you can't control your age, right? We all get older at, 1 minute per hour, per day, whatever it is. We all get older at the same rate. You can't control your gender. So definitely males are more prone to heart disease than females. Race, you can't control your own race, right? That's what you're born with. And then your heredity, which is sort of race, but not specifically. But again, it's genetics. It's what you inherited. Some people inherently are more prone to heart disease. And then major controllable, smoking is the biggest one. Okay, that's the easiest way to decrease your risk of dying of a heart attack. High blood pressure, again, controllable for most people, and high blood cholesterol. Diabetes. So you can see how being generally unhealthy or having these other conditions plays into a heart attack. These guys right here, these are questions you want to ask every person having chest pain. Because this, like we talked about mechanism of injury and trauma, okay? Well, guess what? This is mechanism of injury in heart attacks. Okay, you want to know this history. Hey, are you a smoker or have you ever been a smoker? Do you have high blood pressure? Do you have high cholesterol? Are you a diabetic? You want to know those questions because those all increase the likelihood that they're going to have a heart attack. And then we have minor controllable, such as obesity. I mean, it does play a factor. Obviously, if you're obese, it's more likely that you have poor eating habits, which leads to diabetes and high cholesterol and hypertension. So by reversing obesity, you're more likely to beat off hypertension and high cholesterol and diabetes. Lack of exercise, again, lack of exercise leads to obesity, but it also weakens your cardiac muscle. It makes it weaker, and so that it is more easily damaged when you do have a heart attack. Stress. Stress triggers a lot of heart attacks. Okay, just work stress, road rage, classic scenario. And I actually had a guy this fall started having chest pain watching football game on Sunday. Sunday night football. Told his wife he was having chest pain. She tried to get him to go to the hospital. He wanted to wait till the end of the game. And fourth quarter, I'm there pumping on his chest. Okay. I mean, he took his bare aspirin. He said, I'll take some aspirin. I'm going to wait till the end of the game, and then if I'm still having chest pain, we'll go to the hospital. And, I missed the fourth quarter because I ended up pumping on his chest. Personality, again, people who are real, I want to say that relates more to stress. People who are real wired, okay, it can lead to it. So cardiovascular disease, control of risk factors equals decrease in coronary artery disease, or what we shorthand CAD, and acute MIs, AMI. Okay, what does infarction mean, y'all? Infarction means cell death. Okay, an infarct is cell death. So we have cellular injury, which we call ischemia, and then we have cell death, which is an infarction. And it's not just cell death, like we'll use it in terms of we talked a little bit about blood clots causing strokes, different things in the body earlier. You can get a blood clot in your intestines that causes a bowel infarct, right? Because it cut off blood supply to your intestines and it will kill that portion of bowel. So an infarct means death. So CAD, coronary artery disease. The myocardium, or heart muscle, requires continuous oxygen and nutrient supply. Myocardial blood supply passes through the coronary arteries. So when we're tracing the blood through the heart, it comes up out of the left ventricle, it goes into the aorta, passes through that aortic valve. Well, immediately after that aortic valve, you have a left and a right coronary artery where blood comes out of the aorta and the heart goes back and feeds itself. The heart feeds itself first. Okay? It's the big workhorse, the big machine. It feeds itself first every time. So when that blood comes up into the aorta, it goes right out the coronary arteries and into the heart. Okay, atherosclerosis is a narrowing of the lumen. So the coronary arteries themselves get smaller because of all the crap that's in them. So plaque formation related to the risk factors, high cholesterol especially, that's where the plaque comes from. And then results in decreased myocardial perfusion, or there's less blood, which means there's less nutrients and less oxygen getting to the heart. Poor tissue perfusion causes tissue damage, or what we call ischemia, and tissue death, which is called infarction. Okay? We can pick up both ischemia and infarction on the 12 lead. So anytime you have someone complaining of chest pain and you have ALS available to you with the 12 lead, we can put them on the 12 lead. We can pick this stuff up just like an ER doctor can. Now what the ER doctor can do that we can't do is he can do blood work, which can give us more information. So even we sometimes are stumped, or if it's one of those non-STEMI, there is no changes yet, then we can get to the hospital and they can do blood work. So here's plaque buildup. Here's a normal artery. Okay. Here's one that's getting kind of yucky. Here's one that's less than half, and here's one that's probably causing a pretty good problem, right? Okay. So angina pectoris literally means a choking in the chest. Okay. So choking, what happens when somebody gets strangled or somebody's choking? What gets cut off? Yeah, oxygen, right? This is literally, if you look at this, this is choking the arteries. So it's choking the heart. Does that make sense? You guys see that? So angina pectoris is literally a choking in the chest. Here's the classic, I'm having a heart attack sign. They bring their arm up, they hold their chest. So, angina to choke. Myocardial oxygen demand exceeds supply during periods of increased activity, exercise, or stressful event. Okay? Classic example of angina pectoris is someone who gets short of breath and experiences chest pain while climbing stairs. Classic example. So they live in their house, whatever, but when they try to go up the stairs, they either can't make it all the way up, or when they get all the way up, they're really short of breath and it's causing chest pain. Myocardial oxygen demand exceeds supply. Occasionally, if you guys go out and run real hard or whatnot, you'll feel your chest really starts thumping. Okay, we're young and healthy, so we don't necessarily have pain, but you can see how your heart increases its workload and starts working really, really hard. Well, when you get elderly, and let's say you're a little bit overweight, and you try to climb uphill or upstairs, it gets that heart pumping the same way, but for them, it causes that same amount of short of breath that you may have when you're running, but they also get that angina pectoris, or that chest pain. So during stress, the myocardium demands more oxygen. Coronary arteries would normally dilate to supply more blood and oxygen. So that's how your normally functioning heart will compensate, is the arteries will dilate and more blood and more oxygen will get through to the heart to help it work harder and faster. But someone with coronary artery disease, they're unable to dilate sufficiently enough to increase perfusion because they've been so narrowed. Okay, and the plaque hardens the arteries. It makes them less flexible, so they can't expand the way that they need to. So classic presentation, chest pain, shortness of breath, diaphoresis. What's diaphoresis? Yeah, so when your body gets stressed, it releases epinephrine, okay, or adrenaline. And when that occurs, it causes you to break into a cold sweat. Okay? So we know when we talk about general impression, when you talk about a general impression of a medical patient, when you walk in the room and you see them sweating, you know that there's something serious going on because they are what we call diaphoretic. Okay? And then again, when your body dumps that epi and you go into fight or flight mode, another side effect is it's going to cause nausea and vomiting because your body's going to want to empty. It doesn't want to send any blood to digest food right now because it needs all of its blood everywhere else. So your body's going to dump whatever's in your stomach to try to free up more. Okay? So chest pain, shortness of breath, diaphoresis, and nausea, vomiting. The shortness of breath is usually a sensation of shortness of breath. It doesn't mean that they're going to be breathing 40 times a minute. It doesn't mean that they're going to have real yucky lung sounds. It's more of the patient telling you, I can't breathe. I feel short of breath. And you'll kind of go like, well, what do you mean you can't breathe? You're talking to me. You can breathe. I'm listening to you. Your lung sounds sound fine. But they're going to tell you, I can't breathe. I'm not getting enough air. I need more air. They're going to have this air hunger. Not all patients read the textbook, so remember, they're not all going to complain of exactly that. Symptoms of angina pectoris. Pain should be substernal, meaning inside the chest. So they'll be complaining of chest pain. Well, when we assess a person with chest pain, the first thing I want you to do is when they say, oh, my chest hurts, you're going to walk up and push on their chest, and you're going to listen to their chest. Okay? If you can push on their chest and they say, ow, 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 oh, that really hurts. Or when they take a big, deep breath, they say, oh, yeah, that hurts to take a big, deep breath, then it's probably not cardiac. Okay? But when someone who has legitimate substernal chest pain, meaning you're not able to recreate it, squeezing, crushing, heaviness are terms that they use to describe what they're feeling, may radiate to arms, shoulders, jaw, upper back, or upper abdomen, or back. May be associated with shortness of breath, nausea, and sweating. Okay? Those are your classic chest pain symptoms. Pain usually associated with the 3 E's: exercise, eating, and emotion. So these are triggers for what causes people with angina pectoris to have these symptoms. Okay? So again, this goes back to the classic exercise of climbing up the staircase caused me to start having this chest pain. Okay? Symptoms, so the pain seldom lasts more than 30 minutes. And pain relieved by rest. Okay, so if exercise was the cause, rest should be the treatment, right? Nitroglycerin. So if they did just need some help getting more blood to the coronary arteries, nitroglycerin, which dilates those coronary arteries, then it's going to restore that blood flow and help them feel better. So, guys, this is important. To be angina pectoris and not a heart attack, it is the same symptoms, okay? Go back here. It's the same basic symptoms, right, of chest pain. They may use terms squeezing, crushing, heaviness. It may radiate around their body. But if it's a real heart attack, it's not going to get better on its own. It's only going to get better when we get them to the hospital and get it fixed, okay? Angina pectoris, within 30 minutes of the onset, with rest and nitroglycerin, fixes on its own. Okay? If this doesn't fix it, it's not angina. It's something else. Okay? It's something worse. So, symptoms, great anxiety, fear. People will call you because they think they're having a heart attack. Fixation of the body. They may not want to move very much. They may be pale, ashen, or livid in the face. May have dyspnea or shortness of breath. Nausea, diaphoresis. Blood pressure usually up during the attack. Okay? Again, they're going to be kind of stressed out. They're going to dump that epi, causing these. It's also going to cause their blood pressure to increase. Dysrhythmia may be present, may start their heart beating irregularly. Following an angina attack, there is no residual damage to the myocardium. Okay? That's what's key here. If it was an acute MI, which we'll talk about in a minute, there's actual damage occurring to the heart muscle. If it's just angina pectoris, they're going to have all those symptoms, but when they rest and they take their nitroglycerin, the pain's going to go away, the workload's going to decrease on the heart, and there's going to be no residual damage to the myocardium. Okay? So a lot of doctors who are treating patients that they know have coronary artery disease, they'll prescribe them nitroglycerin, they'll tell them to take an aspirin a day, and they'll tell them, hey, if you're climbing stairs or, if you're walking through the mall, whatever it is, and you start having chest pain, sit down, rest, take up to 3 nitroglycerins 5 minutes apart, and see if it goes away. If it goes away, they say, kind of no harm, no foul, go about your day. If it continues for longer than 30 minutes, or if those 3 nitros don't help, then it's time to go to the hospital or call 911. So we'll get called to a lot of people with chest pain, and they'll have waited 30 minutes or an hour. They'll have taken their own couple of nitros before we even get there, and then they'll say, hey, this happens to me it happens to me twice a week, but today it's not getting better. So forms of angina pectoris, stable angina, that's what we were just talking about, occurs generally with exercise. It's predictable. Okay, again, it happens to them twice a week or whatever, or every time I climb the stairs this happens. Relieved by rest or nitroglycerin. Okay, unstable angina, more frequent or more severe than the normal episode. Okay, these people, it's usually not their first episode. Remember, these people, they've talked to their doctor about it. He's given them a treatment plan. It occurs every so often. But today, it's worse, or it's more frequent, or it's not going away. It's not getting better. So it's not following the normal pattern. Can occur during rest. If it occurs during rest, or our classic example again, if it wakes you up from your sleep, then it's not angina, right? Because during your sleep, you shouldn't be stressed out, you're not eating, and you shouldn't be exercising. So if it wakes you up from your sleep, there's no way it's angina pectoris. Okay? If it wakes you up from your sleep or while you're just sitting watching TV, then it's a heart attack till proven otherwise. So may indicate impending MI. Doesn't always show up as an MI right away on our little chart. It doesn't mean that that artery is not 80, 90% blocked and that the cath lab can't go in there and fix it. Okay, questions about angina pectoris?
So, unstable angina pectoris, is that pretty much just an indicator of something else?
Right. So stable angina pectoris is someone that has an episode and they kind of expect it. Yep, I knew that if I got on the treadmill, I would probably have chest pain. But I need to lose weight, so I did this, whatever. Or, a lot of people recovering from surgeries, different things. I don't know if I told you guys this. Okay, I used to be an aquatics director for a YMCA. We would get a lot of these people come down to our pool to do water aerobics because it's easier for them to exercise and get in there. Well, every so often, these big 300-pound people or whatever, they're going to get short of breath. Okay, they're going to have some chest pain, but they have their little nitro. They wear it as a necklace, whatever. They go climb out of the pool, sit on the bench, take their nitro. They expect that they're going to feel a little bit poorly while they're exercising, but they're trying to strengthen their heart. They're trying to lose weight. They're trying to get better. But if it becomes more frequent, or if it's more severe than normal, or if it doesn't improve with the rest of the nitro, then we're thinking it's probably an AMI. At that point, it's unstable angina, and we need to do a lot more to try to help them. Okay, any other questions? All right, heart attack, inadequate perfusion of the myocardium, death of the myocardium, infarct, right? That's that big word, infarct. Damage to the myocardium, ischemia. So this is damage. So think of this as dead cardiac tissue or cells. This is injured cardiac tissue or cells, not necessarily dead. So, and it normally, I believe the next slide, well, maybe it doesn't show you. Usually when you have a cardiac event, and I'll draw it up on the board, you have an area of heart tissue that is killed, that's dead, and then you have an area that's injured. So, okay, so here's my heart, right? And here's my aorta comes off, and then I have my coronary arteries, one this way, one this way. This one comes around and then bifurcates and branches. This one wraps around and comes down over here. Okay? If I get my blood clot occurs right here, okay, there's a region of the heart now, yay big, that's not getting the blood supply that it needs. Okay? But you may have, while that's all ischemic, you may have this amount that's infarcted, dead, never going to come back, can't fix it. But if we can get in and relieve that clot, then all of this ischemic area we can restore. Okay? And usually you have a little bit of ischemia here because you get, the further out you are, you're going to get a little bit of collateral circulation from these other arteries. Okay? So they have little arteries that come off of the three big ones. But you can tell distally down here, where this is the only artery that feeds it, it's not going to be getting any blood. Okay? So anytime you have a heart attack, you're going to have both ischemia and infarct. So chest pain is a cardinal sign of an acute MI. Occurs in 85% of MIs. That's a good thing, right, for us, because people can call us when they have chest pain. For that other 15%, that's a real bummer, huh? It's usually substernal. Remember, substernal. And I want you guys to use the term of, like, this says chest pain, right? Well, I can cause chest pain in all of you. Just come stand in front of me. I'll punch you in the chest, and you'll have chest pain, right? Okay. Cardiac chest pain. When you're running scenarios with me, when you're treating somebody, when you're talking about patient care, it's not just chest pain, it's cardiac chest pain. Okay? We're going to give aspirin, nitro, and oxygen to cardiac chest pain. You're going to need to ask your questions, do your associated signs and symptoms and your pertinent negatives, do your assessment to try to determine if the chest pain is cardiac chest pain or if it's another chest pain. Because if it's his lungs, if it's a pulmonary problem, then we may not want to give nitro. We may want to give something else. Okay? It depends on what is causing the chest pain. And obviously, if it was trauma, if it's because Lorenzo got punched in the chest, that's, again, a different treatment. That's an ice pack, not aspirin and nitro. So, yeah, that's what we're looking for. Patient will usually, because it's in the heart, okay, it's deep in the body, it's not a place that people are used to feeling pain or used to describing. So when they feel it, they'll use terms like crushing, squeezing, tight, heavy. You'll ask them where it hurts, and they'll just kind of say, well, in here, in here. It's not like they can just say, oh, well, it's my right ring finger on my hand. You know, they can't pinpoint it to that point because it's inside of them. It's hard to say. It's kind of, if you've ever had a stomach ache, you kind of say, oh, well, my tummy hurts. It's like, well, okay, well, where or what in your tummy hurts? It's real difficult to get that specific. You can just say, oh, I've got a tummy ache. So chest pain may radiate to arms, shoulders. Commonly, especially in women, it radiates to the jaw, upper back or upper abdomen back. So same as angina pectoris, right? Okay, again, we're looking for the stable versus the unstable cardiac chest pain. May vary in intensity. So some people, it may just be a dull 3. Other people, it may be a 15 on the 10 scale. Okay? Unaffected by swallowing, coughing, deep breathing. Again, associated signs and pertinent negatives. If I say, okay, so you're having chest pain, breathe really deep for me, and that causes them to start coughing and gagging and hacking, and they say, oh yeah, that made it a lot worse. Okay, that's a lung problem. They've got an infection. That's not a heart attack, right? So that's the type of questions you want to be asking. Or, swallowing, maybe it's a sore throat, or maybe they got something stuck. There's several different things. I will tell you that a lot of people that are having a legitimate heart attack will sometimes say it feels like they have a tight throat or something stuck in their throat. It kind of has that referred pain going up the neck into the jaw where they'll say, yeah, it kind of feels weird. And then any movement. If they say, if you pushing on their chest and moving their ribs or whatever, or if them getting up, walking around makes the pain worse, then it's probably musculoskeletal versus cardiac. If it's the heart and the heart's having an injury, there's not really anything, any position, anything like that you're going to be able to do that's going to make it feel better. Okay, so chest pain unrelieved by rest and nitroglycerin, which is, remember, that's our criteria for kind of stable versus unstable. Pain lasts longer than angina pain, up to 12 hours. Silent MI. 15% of patients with an MI, it will be a silent MI, and we'll look for, so basically silent MI means that they don't present with chest pain. It's not really silent though, okay? Don't think of this as, okay, so they're going to have no symptoms because they're not having chest pain. They might have abdominal pain. They might have flu-like symptoms where they're real nauseated, vomiting. They may have diarrhea. They may have a syncopal episode where they pass out. They may feel extra weak and have difficulty getting around the house. There's going to be something occurring. You can't have damage occurring to the heart and not have some sort of outward signs. Silent just means they're not presenting with chest pain. Particularly common in females who are elderly and diabetic. Okay, those are the people who have silent MIs. Shortness of breath, weakness, dizziness, and fainting, nausea, vomiting, pallor, and diaphoresis. Those are all symptoms of an AMI. Sense of impending doom. A lot of these people will say, I feel like I'm going to die. Okay? That's a bad thing because sometimes they're right. Denial. Some people, oh, it's just indigestion. That's common. Oh, I just need some Tums. It's heartburn. I'm just having some heartburn. 50% of deaths occur in the first 2 hours, so the denial is what kills a lot of these people. Case in point, my guy watching the football game. Oh, it'll get better, okay? Average patient waits 3 hours before seeking help. Okay, they start having symptoms, they get up, they walk around, they drink some cold water, they try to lay down and go back to bed, they take their aspirin, they take their nitro, and then it finally dawns on them that, you know what, this is not getting better. Other symptoms of acute MI could be changes in pulse, blood pressure, respirations are not diagnostic of an MI. So you can have heart arrhythmias and problems that don't indicate an MI. However, if your heart has sustained damage, you may also see these changes, right? You can go into cardiogenic shock, but not every heart attack is going to go into cardiogenic shock, especially if you get there early enough and are trying to help them. So while it's not diagnostic, obviously someone who is presenting to you with changes or with signs and symptoms of shock, they're going to be a priority patient that you need to get to the hospital. Early recognition of an MI is critical to the patient's survival. Okay? Again, most of them die within the first 2 hours. So we want to get them to the hospital and get them treated as quickly as possible. When in doubt, manage all chest pain as an MI. Do you guys think that you will be faulted for taking someone with stable angina to the hospital to do blood work and be seen by a doctor versus letting someone who is having a heart attack stay at home? Which one do you think is going to get you in more trouble? Yeah. So always err on the side of caution. We again, and I've talked to you guys a little bit about refusals, that type of thing. We never ask the patient if they want to go to the hospital. We ask them, which hospital do you want to go to? Okay? If they called 911, we're going to assume that they want to go to the hospital. So we're going to ask them, which hospital can I take you to? Or we're going to say, hey, St. David's Round Rock is really close. They're a good cardiac center. Let's take you there and get you checked by a doctor. Okay? Then if they voluntarily say, hey, you know what, I don't really think I need to go to the hospital for this, then you can have that discussion of, okay, well, maybe you don't go to the hospital, but this is what you need to look for. We're not going to voluntarily suggest to someone, hey, I don't really think this is a problem. If they thought it was a big enough problem to call you there by calling 911, you're going to ask them, which hospital do you want to go to? Okay? Begin management immediately if angina or MI are suspected. Okay? Complete the history and physical exam as you treat. Okay? So if I suspect, so let's say, again, Lorenzo, he calls me to his house for chest pain. I come in and say, hey, Lorenzo, I'm Ethan, I'm with EMS, what's going on today? He says, well, I feel like I can't breathe and it feels like an elephant sitting on my chest. I'm going to say, okay. Have you ever had this before? He's going to say, nope, never had this before. I'm going to say, okay, what kind of medical history do you have? He says, well, you know, I have high blood pressure, high cholesterol, and, you know, I used to smoke. And I say, okay, well, those are all risk factors for a heart attack, right? So let's assess Lorenzo for a heart attack. I'm going to have my partner start getting me some vital signs. I'm going to say, Lorenzo, show me where you're hurting in your chest. And he's going to point, kind of hurts here. I'm going to ask, does the pain go anywhere else? And he's going to say, well, it kind of goes into my left shoulder, and it kind of makes my left arm feel a little bit tingly. I'm going to say, okay, that's consistent with a heart attack, right? So then I'm going to listen to Lorenzo. Lorenzo, take a big deep breath. Does that change your pain in any way? He's going to say, no, it still feels right here in the center of my chest. I'm going to push on his chest. Lorenzo, does this change the pain at all? He's going to say, no. I'm going to, Lorenzo, has anything you've done today made it feel better or worse? He's going to say, no, I tried to drink some water. I tried to lay down and take a nap. It's just not working. Lorenzo, what were you doing when this pain started? I was sitting here watching the Andy Griffith show. Said, so you weren't real excited, you weren't exercising, you weren't doing anything. He said, nope, I was just sitting here and drinking my iced tea and watching Andy Griffith. Okay, that sounds like a heart attack, right? Sounds like a heart attack. So at that point, I'm going to say, Lorenzo, are you allergic to any medications? He's going to say, nope, not allergic to any medications. Are you taking any blood thinners? Have you had any blood in your stool or your bowel in the last couple of days? Said, nope. Said, okay, Lorenzo, I want you to take 324 milligrams of aspirin. Okay? Am I done assessing Lorenzo or talking to Lorenzo? No. But I know Lorenzo needs aspirin. I'm also going to have my partner, hey, let's get Lorenzo on 3 liters of oxygen, nasal cannula. I'm going to get my vital signs. Rachel, what were the vital signs? If his blood pressure is good and his heart rate's good, I'm going to say, hey, Lorenzo, we're going to give you some nitro to try to help with this pain. I want you to let me know if it makes you help. So what's your pain right now on a scale of 1 to 10? He says, well, it's a 10. I'm going to give him that nitro. Hey, you should feel some tingling under your tongue. It may give you a little bit of a headache. Okay? Make sure that he hasn't taken any Viagra, Cialis, anything like that in the last 24 hours because that could kill him. Or beta blockers in the last couple hours because that could kill him. And give him the nitro. Okay? So I'm going to treat him as I'm assessing him as quickly as I can. I'm still not done. I still haven't asked, well, when was the last time you ate? Or I still haven't gotten his complete list of medications. But I know he's not allergic to these 2 medications. I can get him going on them. The sooner, the better. Okay? You guys see how that we're going to start treating as soon as we can. Because time is everything. Request ALS, again, we can do the little squiggly line thing and some IVs, that type of thing. We give narcotic pain medication to people having heart attacks because it is very painful. Again, as long as their blood pressure is good enough. Place the patient in a position of comfort for them. Most of them are going to want to be kind of sitting up because, again, they feel like they're a little bit short of breath. Make sure that their airway stays patent. Deliver oxygen to maintain an SpO2 of 94% or greater. If they're satting 100% already, then they do not need supplemental oxygen. Okay? There's some studies out there that they're doing that are showing that over-oxygenating a patient can be harmful. So as long as they're over 94%, we're not going to worry about giving them oxygen on the SpO2. However, if you think they're legitimately in respiratory distress, the pulse ox does not override you in your assessment, right? Okay, so just because this is reading 94 does not mean that you can't say, hey, I get that, you're 99%, however, you are working to breathe, I'm going to try to help you. Okay? Reassure the patient. For a lot of people, this is going to be scary, especially the more elderly people, because generally the elderly people are scared anyway, because they know someone, either family, friend, the neighbor down the street, they know someone who had the ambulance come to their house, pick them up, and they never came home. And these guys are scared to death that one day the ambulance is going to come to my house and I'm never going to come home. And it doesn't necessarily mean that they're going to die. A lot of them, they don't want to be in a nursing home. They don't want to be separated. I did CPR on a gentleman the other day. His wife, they were both in their 90s. They had been married for 77 years. Okay? They don't want to be separated. Obtain history and physical exam. Aspirin, 325. We give 324 because we give baby aspirin, and we give 4 of them, and it equals 324. They're 81 milligrams each. This has significant effect on clot formation. Believe it or not, I know you guys, okay, Bayer aspirin commercial, whatever. Aspirin is the one drug that you guys as EMT basics can give that might save somebody's life while having a heart attack. Okay? And same with me as a paramedic. I may be able to save their life by getting aspirin on board as soon as possible. Now, the problem with aspirin and the reason we give baby aspirin is they're going to chew it up, they're going to swallow it. It takes a little bit for it to be absorbed. That's why we give baby aspirin instead of adult aspirins, because it gets absorbed a little bit faster. Okay? And what does aspirin do? It's a platelet aggregate inhibitor. It inhibits the formation of clots. So if you do have a clot forming in the artery, it prevents the clot from getting bigger. It doesn't break the clot, it doesn't make the clot disappear, but it keeps it from getting bigger. So if your clot has occluded 90% of that coronary artery, by giving aspirin, you may keep that last 10% still open, okay, and squeaking just that little bit of blood through. So nitroglycerin, 0.4 milligrams. When we look at medication doses, it's 0.4. It's not just 0.4 milligrams, it is 0.4. Okay? And make sure when you write it, that type of thing, make sure the decimal's in there. But it's 0.4 milligrams. Without the decimal, it's 4 milligrams. And that changes the dose significantly. That's 10 times the correct dose, right? So it's 0.4 milligrams. And it's sublingually under the tongue, let it dissolve. Ask about erectile dysfunction medications. That's your Viagra, your Cialis. Those cause the same basic, they have the same basic activity on the body, which is vasodilation. Okay? That's how that works down there. That's how nitro works. It also causes vasodilation. So if you've taken one of these long-lasting Viagra pills that vasodilates you for 24 hours, and then you add nitro on top of it, you could irreversibly bottom out the patient's blood pressure and kill them. You could put them into irreversible shock.
I have a question. If their blood pressure is stable, does it still matter? Like, why would it matter if their blood pressure is stable?
You don't. So with medications, there's something that has to be reached called a therapeutic threshold. Okay, so if I'm treating your pain, and let's say you have a broken leg or whatever, and I'm giving you a drug called fentanyl, okay, and I give you the first 100 of fentanyl, and your pain stays at a 10. And then maybe I give you a second 100 of fentanyl, and now your pain drops to a 7. And then I give you a third dose of only 50 mics of fentanyl, and your pain drops to a 2. Because I've reached the therapeutic threshold in you, meaning I've hit all the receptor sites in your body that I need to hit to target. Well, it kind of works the same way with nitro. If that Viagra is on that brink of that therapeutic threshold. Okay, it's in the right spot. If I give nitro and I push them over that, I can tank everything. Okay, so you just don't know. Are there patients who take Viagra and nitro and probably do fine? Yes, but you don't want to be responsible for the one that you give too much to. So again, that's usually ED medications within 24 hours. Okay, patient should be sitting or lying down. You don't want them standing up because again, it is going to cause their blood pressure to decrease. Has patient taken nitroglycerin in the last 10 minutes? Is pain relieved? Did they get any sort of headache? So a lot of patients are prescribed their own nitro. They have it at home. They take it every day. Sometimes the nitro gets ruined. It gets heat exposed, or it gets wet, or it gets old and expired, and so it doesn't work. What you don't want to do is give them too close together, so you want a little time to go through, so whatever effect the nitro they took. Nitro, it only lasts 5 to 10 minutes. Okay, so whatever effect the nitro that they took was going to have is usually gone within 10 minutes. You want to know, did it help? Because one, that's an associated sign or symptom that, hey, I was having chest pain, I took a nitro, and it made my pain less. Then that's kind of diagnostic for, okay, it is the heart that's being affected. And did it cause tingling under the tongue or a headache? Nitro, when it vasodilates, causes headaches. Okay? And that's a normal response. But if they're taking their own nitro and it's not causing a headache and it's not helping their pain, then their nitro may not have been any good anyway. So you may want to continue with your own. Is blood pressure greater than 100 systolic? This is the minimum blood pressure that a patient has to have in order for you to give nitroglycerin. If their systolic blood pressure is less than 100, you cannot give nitro because you'll lower their blood pressure too far. Okay? And then kind of, again, that's an arbitrary number. Use your common sense. If it's 104 and they look bad, you may not want to give it to them. Or if you gave them the first nitro when they were at 120 and it dropped them 18 points to 102, you don't want that second nitro to drop them another 18 points. Okay? So kind of, okay, that was a big drop or a pretty decent drop. I may not want to give you another nitro till your pressure comes back up to 120. Okay? So every time we give a nitro, we want to check the pressure before and then after. So check a pressure, make sure it's okay, give the nitro, and then about 5 minutes later when you're starting to think about giving another nitro, check the pressure again to see how much it dropped. Every 5 minutes until pain is relieved. Usually you can give 3 nitros per your protocol. After those first 3 nitros have been given, that's 15 minutes. Hopefully ALS is there and they'll be taking over. If not, you'll probably need to call to see if you need to continue with the nitro. But again, that'll be that's the standard, but again, your medical director may give you different guidance when you get out there. But usually what they'll tell you is every 5 minutes up to 3, and then do something else. So management of chest pain, again, transport in a semi-sitting position if blood pressure is normal or elevated. Lay them flat if the blood pressure is low. Early notification. As soon as you, for me, I walk in a house, somebody presents with chest pain, I'm going to put them on my 12 lead, and I'm required by my medical director, he wants me to have a 12 lead within the first 5 minutes of being on scene. As soon as I know that that patient's having a STEMI acute MI, I am to call the ER physician directly on a cell phone and tell him what's going on as soon as possible. You guys are kind of in the same boat. If you're treating your patient ACS, you think it may be a heart attack, the earlier you can radio into the hospital, let them know what's coming. They'll activate the cath team, get an ER bed ready, all of that type of stuff that they need to treat this patient. So the earlier the hospital's notified, the better for the hospital. If they are having a heart attack, do not walk patient to the ambulance. Okay? This patient is to be carried, lifted, rolled, whatever you got to do. You don't want them standing up. One, it puts more workload on the heart. They run a bigger chance of having a syncopal episode or passing out, and it can increase the damage on the heart by increasing their myocardial oxygen demand. Okay? So you don't want to walk them to the patient. When you increase that myocardial oxygen demand, as the heart's getting damaged and irritated, the more irritation that occurs, the bigger this kind of bubble gets, the more likelihood that they will go into an arrhythmia. The arrhythmia will kill them immediately if they go into VFib, possibly VTAC. Okay? You don't want that. You don't want them going into an arrhythmia. So you want to be as careful with them as you can and hoping to just get them to the hospital where they can go in and fix it correctly. Okay? If you stress the heart out too much and they go into that arrhythmia, then they can die very, very quickly. Do not use lights and sirens if patient is awake, alert, and breathing without distress. Okay, this is for you guys as basics. Your patient's having chest pain, but he otherwise appears completely stable. Okay, then it may just be angina pectoris. It may not be an actual STEMI. For me, where I can take that picture and I can say, yep, it is a STEMI, then I'm going lights and sirens. Okay, so that's different, even if he is, quote-unquote, stable. But I have a diagnostic image. So for you guys, if the patient is stable, you may not need to use lights and sirens. Monitor vital signs, Q5. Request early ALS backup or rendezvous. 12-lead EKG helps determine treatment. We've talked about that. Deaths and MI result from arrhythmias. I was just talking about that. Arrhythmias can be prevented with early drug therapy. Again, ALS, we carry several different medications to help treat different heart arrhythmias. Okay, questions about an acute MI? Okay, why don't you guys take a 5-minute break and we'll continue this lecture when you come back. Go stretch, get the wiggles out. Any questions? Okay, so hypertension. Again, a chronic disease can somewhat be reversed. Like you don't have to be hypertensive forever. There's things that you can do to prevent it or change it. Medications, things, losing weight, things like that. Means high blood pressure. We already talked about how that's measuring the pressure on the walls of the artery. It can be chronic or an acute event. Pathophysiology, increased pressure to the organs, reduces blood flow, and causes increased afterload. Remember, the afterload is the amount of blood remaining in the left ventricle after it contracts, right? Well, why would hypertension cause the afterload to be increased? Because the ventricle has to push harder against that pressure to get the blood out of the ventricle. So the harder it has to push, the more likelihood that some of that will remain. So that, in effect, reduces the blood flow. It reduces the amount of blood that's able to get out. Hypertension is an emergency if systolic blood pressure is greater than 160 or the diastolic is greater than 90 or 94. Okay? So classic hypertension is defined as blood pressure of 140 over 90. Hypertensive emergency signs and symptoms. They may have a very strong bounding pulse. Skin may be flushed. Skin may be dry or moist. Commonly it causes a headache, ringing in the ears, nausea, vomiting, and can lead to nosebleed or what we call epistaxis. Management, you're going to do a history and physical on the patient. Supportive care, we're not going to treat the hypertension. You're not going to give them nitro to try to lower their blood pressure, because if the hypertension is caused by, say, a stroke or a bleed in the brain or the head, and you give nitro, you make the bleed worse and you can kill your patient. So we, in EMS, we do not treat hypertension. Okay? We transport them to a hospital for further evaluation. We can do supportive care, such as positioning, give them some oxygen. If they're real nauseous, maybe paramedics will give some nausea medication or something. However, we're not going to try to lower the blood pressure on our own. Okay? Just transport them to the hospital. Congestive heart failure, known as CHF, inability of heart to pump blood out as fast as it enters. Okay? So this is kind of that preload, afterload battle. Okay? So if I have, say, high blood pressure, my pressure's high all the time, and I'm getting a lot of resistance, my left ventricle isn't able to pump out very well. And my left ventricle will get tired. It may also get damaged to where it, maybe there was some sort of heart attack or something that has weakened the left ventricle that makes it even harder for it to pump. So we got a pump problem. Well, the pressure coming back is too close to the pressure going out. You'll start getting more preload and more afterload at the same time. Okay? So where is that blood? If it's pooling in the heart because it's coming in from both ends, where is it going to go? If you got blood coming in the right atrium and you got blood backing up in the left ventricle, so both ends of the heart, where is the blood going to go?
It's going to back up into the lungs, right?
Right. It's going to back up into the lungs. Because that blood that comes in the right atrium is going to go to the right ventricle, and the right ventricle is going to pump it where? To the lungs. Okay? And the blood that's coming back into the left ventricle, once it fills the left ventricle, it's going to start backing up into the what? The left atrium. Okay? Once it fills the left atrium, it's going to start backing up what? The lungs. So now you got a strong right ventricle pumping blood into the lungs, and you've got a weak left ventricle that can't pump the blood out. So where does the backup occur? In the lungs. Okay, so type left-sided or right-sided. So it could be the right or the left ventricle that's affected, or it could be both, which is kind of what I was just describing. Causes of CHF is coronary artery disease, chronic hypertension, or an acute MI, or valvular heart disease. And that's what we're not really going to get into the heart valves, but just know that if I have a leaky heart valve, that can also cause blood to back up into the lungs. Okay, usually begins with left-sided failure, which is what I was just describing to you guys. The left ventricle gets injured and you start having an afterload problem. Increased workload on the left ventricle fails, blood stacks up in the lungs. Okay, what does the blood do in the lungs? Causes you to be short of breath, literally floods the alveoli and causes you to drown. Okay? High pressure in capillary beds, fluid forced out of capillaries into the alveoli. So right-sided failure most commonly caused by left-sided failure. Blood backs up into systemic circulation. So right-sided failure means the right ventricle is affected. So if the right ventricle is affected and we start getting afterload in the right ventricle, then that's going to cause afterload in the right atrium. And where's that blood going to back up? In the body, in the vena cava. So these are the people that we're going to see have real swollen ankles. They have ascites of the abdomen. They're going to have the signs and symptoms of pedal pulmonary edema, or that pitting edema in the ankles, because of right-sided heart failure backing up. But remember, right-sided failure is most commonly caused by left-sided failure. Okay, because it backs up the whole system. And then once the peripheral, once your legs and ankles and abdomen are as swollen as they can get, then there's no choice but for it to back up into the lungs. So these people are going to commonly want to stay very upright. They're going to have very distended neck veins because the blood's not going to be able to return. Fluid in the abdominal cavity, which we call ascites, and the pedal edema. These people are going to be very weak because they've got very little cardiac output. They're going to feel short of breath pretty much constantly. That's going to increase with exertion. It's just going to get worse. And they have paroxysmal nocturnal dyspnea, meaning they can't sleep laying down. They have to sleep sitting up. So a lot of these people will start sleeping in recliners, or they will have dozens of pillows on their bed and sleep propped up against the headboard. They can't lay flat or they'll start to drown. Attacks of shortness of breath that usually occur at night that awakens the patient. Okay? When they try to sleep, they have a hard time because every time they fall asleep, they get relaxed and it causes them to get short of breath. Orthopnea, difficulty breathing in any position other than standing or sitting. So again, they have to stay real upright. Abdominal discomfort as their belly swells. It's going to get very painful. JVD, pedal pitting edema in the lower extremities. When we measure edema, when we call it pitting, that literally means you can squeeze it or poke it with your hand and it will indent X amount of centimeters. So usually we have 1 plus 1, 2, 3, or 4 plus pitting edema. Okay, so we'll say pitting edema at 1 centimeter, pitting edema at 2 centimeters, or 4 plus, meaning 4 or more centimeters pitting edema. So symptoms, they'll be tachycardic. They may have pulmonary edema. How are you going to detect pulmonary edema? Blake, how are you going to detect pulmonary edema?
Crackles? Or no, absence lung signs.
Okay. So it's crackles or rails, but how are you going to detect it? What assessment are you going to do?
Auscultate.
Auscultate. Good. You have to listen to lung sounds. So they may have noisy or labored breathing, coughing. The coughing may be pink or kind of pink, bloody sputum. Rails and wheezing. It can cause some bronchospasm. Okay, here's someone with chronic heart failure. Okay, they're going to be mostly sedentary. You know, they're going to sit around all day because they don't have very much energy. They're going to have swollen, pitting edema in their ankles, usually a distended abdomen. They usually look a little pale. They're going to have a slightly tachycardic heart rate. They're going to be breathing a little bit faster. They may have fluid in the lungs that you can hear. They're going to look cyanotic around the mouth. Distended neck veins. They may complain of recent rapid weight gain because they're retaining fluid. And they usually have a history of hypertension as well. So management of CHF, sit the patient up, let their feet dangle. A lot of time we got to let their feet they kind of straddle the stretcher while they're sitting on it, and their feet kind of touch the floor. Still need to put seat belts on them. Oxygen, again, maintain at 94%. CPAP or PEEP as needed. So continuous positive pressure ventilations. CPAP is designed for CHF. That's what it's designed for. And what it does is it splints the lungs open and reverses that pressure gradient. So the reason the blood is backing up into the lungs is all based on pressure causing afterload and preload and everything backing up, right? Well, by putting positive pressure into the lungs, I literally put pressure on those alveolar capillaries and I push that fluid back into the circulation. Okay? And you guys all remember holding that mask up to your face, right? It's blowing. Okay? And we're literally trying to blow that blood back into the circulation. So monitor vital signs every 5 to 10. Request early ALS backup. Questions about CHF? Is this someone that we're going to give a whole bunch of medications to? We're going to give oxygen. If they're wheezing real bad, you may consider albuterol. But know that albuterol increases what? What's a side effect of albuterol? increases the heart rate. And if your heart's beating faster, that's going to make it more difficult for it to pump efficiently and may actually be harmful to them because it may cause even more blood to back up. So CPAP is the gold standard. Okay? If CPAP starts working, whatnot, then you may consider the albuterol. Don't just go with albuterol because you may flood their lungs even more. So be careful with that. Okay, pacemaker failure. A lot of people get internal automated defibrillators placed in their chest. Okay, position of comfort, patent airway, oxygen to maintain 94%, assist ventilations as needed. So usually these people will still have a heartbeat if the pacemaker fails. Usually it's just a demand pacemaker, which means anytime their heart rate drops below like 60, then the pacemaker will kick in. Okay, so hopefully they still have a pulse. It may be slow. It may be really wild and irregular, maybe the problem. There's a lot of different reasons that you get a pacemaker placed. So you need to, keep tabs on their pulse and kind of see what's going. You may obviously want to consider ALS intercepts because we can put them on the monitor and really see what's going. But also our monitor has a pacer function where we can take over pacing for the patient if it's needed. Okay? CPR is needed. If they get too bradycardic, you can start chest compressions on them. Okay? You are not going to hurt them because they have a pacemaker by doing chest compressions. Okay? Yes, it's not going to hurt anything, but even if it does hurt something, you're taking them to the hospital anyway. You're hopefully saving their life by doing chest compressions, and if the doctor has to replace it or fix it anyway because it's having some sort of problem. So you do what you got to do, but just don't be afraid to do chest compressions on someone with a pacemaker. Okay? Implanted defibrillator, a lot of them are the same device now. It's a pacemaker defibrillator, kind of whatever you need type of thing. It usually goes in the left chest. It's the size of, size of like an Oreo cookie, hard metal. You can feel it in there. Sometimes if they're real skinny, you can see it. If performing CPR on a patient, implanted defibrillator may fire. Okay? May feel a slight tingle, however, it's not going to hurt you. Okay? So again, don't worry about doing CPR on someone with a pacemaker or defibrillator. It's not gonna shock you. Cardiogenic shock, inadequate perfusion related to the heart. So the problem is a pump problem, correct? Inability of heart to circulate blood could be MI, could be valve failure, could be a tachyarrhythmia. We've talked about heart arrhythmias being a problem. Or a bradyarrhythmia or bradycardia, so the heart beats either too fast or too slow, which causes it to not have sufficient cardiac output. Could be cardiac tamponade. You guys know what that is from trauma, right? Signs and symptoms, altered mentation, pale school skin, delayed capillary refill, and there could be other symptoms based on the cause. Obviously, tamponade, he may have chest injury and JVD and all this other stuff. But at a minimum, you're looking for these signs of shock of delayed capillary refill, pale cool skin, altered mental status. You could have a very fast or a very slow pulse. So the pulse rate itself is not necessarily indicative. Or like in the case of an MI, it may be a normal pulse rate. So you can't always gauge on that tachycardia in cardiogenic shock as being a sign and symptom of shock. Because it may be, or it may be that it's very slow, or it may be normal. So that's why it says that others based on cause. Depends what the cause is. Management's going to be basically the same. Request ALS, position supine, maintain the airway, assist ventilations as needed, oxygen greater than 94%, keep them warm, and rapid transport. If you can find a quote-unquote reversible cause, That's what we're going to do as paramedics. We show up, okay, if it's too slow, we're going to try to speed it up. If it's too fast, we're going to try to slow it down. If it's an MI, they need to go to the cath lab. If it's tamponade, they need to go to the OR. You need to be thinking about trying to figure out what's causing the cardiogenic shock and where do they need to go for treatment. Because not every hospital has a cath lab and not every hospital has a trauma surgeon. And so you need to be trying to figure out what is this underlying cause of cardiogenic shock and what facility is going to be best to treat that patient. And maybe there's something you can do, maybe there's not. Obviously, if it's real slow, you can do chest compressions. Okay, that's something that you can do. So, management, reassess the patient as needed, maintain their airway, and again, rapid transport. Well, this is, okay, so cardiogenic shock, same type of thing. Post-cardiac arrest, you show up at a house, you do CPR on someone, you get pulses back, maintain the airway. A lot of the time they don't start breathing on their own, so you're still going to need to breathe for them. And then keep reassessing them, keep checking for that pulse, and rapid transport. We don't generally transport alone with a critical patient. Take someone with you, take 3 people with you, take 4 people with you. Take as many as you need. If you got one person breathing, you need to have probably one other person ready to do chest compressions, and that frees you up to do the assessment. Maybe you want 2 people in there to do chest compressions if needed, or maybe you need somebody in there to be suctioning because the patient's vomited multiple times. Okay? Take all the firefighters, all the helpers you need, especially so that you can kind of step back and direct care and keep assessing the patient. If you get trapped doing chest compressions or if you get trapped ventilating the patient, you're not available to really be thinking about the patient or available to be reassessing the patient. You're busy managing the patient. So try to have enough help around you. You know, a lot of time when you first show up at a house, you may be by yourself, just you and your partner. But as other people arrive, other people show up, you'll form your team and direct the call. Okay? We don't recommend transporting someone and performing CPR. Okay? Again, that's going to be your protocols or your medical director to make that decision. But in most cases, someone who needs chest compressions and defibrillation, that type treatment, it's best to do while you're holding still. So if they arrest while you're in the ambulance, pull over, do your CPR. If you're in a house, do all your CPR there. Try to get ALS to come to you if you can. If you're really, really, really rural, that may not always be possible. Again, you'll have to follow your own protocol. Okay, questions about cardiovascular emergencies? None? Crickets?